Okay, so today I'm going to be talking about the mistakes people make when caring for critically ill pregnant patients and the lessons that we can try and learn from those mistakes. Looking after sick pregnant patients is a stressful situation which we encounter relatively rarely, and so don't have many opportunities to learn from our own cases or learn from our own mistakes. So to try and fill that gap, I'm going to be using this really interesting and unique resource, which is a series of inquiries that have been going on in the UK since the 1950s. This was the first report published in 1957. They're called the National Confidential Inquiries into Maternal Deaths. And this is essentially a nationwide M&M, whereby every death in pregnancy or the postpartum period is reported into a national system, and then they do in-depth investigations into all of those deaths to try and see if there were failings in the care. This process has continued uninterrupted since the 1950s. And my talk today is going to be mostly based on the last 10 years or so of these reports, covering around 600 maternal deaths. In these reports, they found on average that around 40% of cases involved failings of care which may have affected the outcomes. Now, in many cases, those lessons are most relevant to people in obstetrics, but I've tried to pick out the lessons which are relevant to us in the emergency department. So my goals today are to help us identify cognitive and clinical pitfalls when taking care of critically ill pregnant patients, and by doing that, to review some aspects of the presentation and management of life-threatening conditions in pregnancy. I'm just going to start with some numbers. In Canada, 1 in 10,000 pregnancies ends in the death of the mother during pregnancy or in the postpartum period. 1 in 300 pregnant women are admitted to ICU at some point during their pregnancy. And from these 10 years of reports in the UK, for women who died in the immediate peripartum period, 1 in 6 of them actually gave birth in the emergency department or the ambulance. So we do see these cases, albeit infrequently. So what I'm going to do is go through 5 scenarios where there seem to be recurrent mistakes that people made when caring for pregnant patients, and we'll try and pick out what those mistakes were and what we can try and do to avoid them. So the first scenario is the pregnant patient with chest pain and shortness of breath. And we're going to start with some of the cases that were described in the reports. So a 32-year-old female in her second pregnancy, known for severe obesity and smoking, presented twice in the 3rd trimester with chest pain and shortness of breath. On both occasions, she was worked up for a PE, and the PE workup was negative. She was discharged home. At 38 weeks, she had an uneventful delivery by cesarean section. 5 days later, she had a cardiac arrest at home and died. On autopsy, the final diagnosis was ischemic heart disease. Next case is a 29-year-old female. 3 days after her first pregnancy, she presented to the ED with shortness of breath, palpitations, a productive seeming cough, anxiety, and tachycardia. The differential diagnosis of the emerged docs who saw her was a PE versus a resp infection versus just some anxiety. They planned for a CTPA, but the scan was delayed for a few hours because of some concerns around radiation. In the interim, whilst waiting for the scan, she had a cardiac arrest, and they got ROSC. At that point, they did a point of care ultrasound, which showed them what the problem was, but she soon after went into another cardiac arrest and died. The final diagnosis here was peripartum cardiomyopathy. Third case is a 34-year-old female in her 3rd pregnancy, previously well, not known for any medical comorbidities. She presented in the 3rd trimester to the ED with severe chest pain, radiating to the back. She was worked up for a PE and an MI. The workup was negative and she was discharged home. She collapsed at home 36 hours later. She was brought to ED where she had a cardiac arrest. A Perimortem C-section was performed. The presumed diagnosis at this point was a PE, and she was given intra-arrest thrombolysis, but unfortunately she died. The final diagnosis on autopsy was an aortic dissection with tamponade. So the common mistake in all of these cases is that a cardiac or cardiovascular cause for the patient's symptoms was not really considered. We think a lot about PE in pregnant patients, but cardiovascular disease is the commonest cause of maternal mortality. It's twice as common as PEs. And this has been increasingly true in the last 10, 20 years or so as pregnant patients have got older and obesity has become more common. I'm going to talk about a few of the specific pathologies that occur more frequently during pregnancy. First up is coronary artery disease and MI. These patients present really as anyone else does with an MI. There's nothing atypical about the presentation. What's atypical, and the reason why clinicians go wrong, is they don't think of this diagnosis in what seem to be young, healthy women. But pregnancy is essentially a prolonged cardiac stress test, and especially women with pre-existing risk factors, most commonly obesity, but all the usual things like hypertension, dyslipidemia are especially at risk for this. I think it's true that in some very young people who present with chest pain, you don't necessarily always need to get a troponin, but I think in any pregnant woman, you absolutely do. Pregnancy in and of itself is enough of a risk factor, no matter how young they are. What's interesting to realize in pregnancy is that around 1 in 3 fatal MIs in pregnancy are caused by spontaneous coronary artery dissection. There aren't really any obvious risk factors for this. It tends to be slightly commoner in the older pregnant patient. This mostly occurs in the postpartum period or the 3rd trimester. This is going to present like any other MI, and you initially manage it like any other MI. Once these patients go to the cath lab, if a dissection is seen, most of the time they don't actually end up getting revascularization because that doesn't necessarily help. They're mostly medically managed, but as far as we're concerned, we would manage this like any other MI. But just to be aware, even patients who have no cardiovascular risk factors, spontaneous coronary artery dissection occurs with a relatively high frequency in the pregnant population. The next important diagnosis, and that came up in one of these cases, is aortic dissection. Pregnancy increases your risk of aortic dissection 25-fold compared to age and sex-matched controls. Now, that's a relative increase in risk. In absolute terms, it is still relatively low. Just to try and quantify to you how rare or common this is, I used data from other populations, and if you extrapolate it to the population of Montreal and how many pregnancies we have annually, I estimate that there is probably on average around 1 pregnant patient with an aortic dissection in Montreal per year. So I think between all the people on this call over the course of a 30 or 40 year EM career, it's not unlikely that at least 1 or 2 of us will see this. Many of these patients on autopsy and subsequent investigation do have risk factors for dissection, but in the vast majority of cases in the reports discussed here, none of these risk factors were apparent when they first presented. It's commonest in the 3rd trimester and the postpartum period. In the 18 or so cases of fatal aortic dissection looked at in these reports, the diagnosis was initially missed in 60% of them. It's worth mentioning that TEE is a really good modality for diagnosis in these patients. And TEE has similar test characteristics as a CT of the aorta. You can get it at the bedside in an unstable patient, and obviously you don't have the radiation concern that you would with a CT. Okay, the next important group of diagnoses in terms of cardiovascular conditions, and what we saw in the third, or in one of the cases I talked about, is cardiomyopathy. This is not just peripartum cardiomyopathy. In fact, only a minority of cases of cardiomyopathy in pregnancy are because of peripartum cardiomyopathy. Other diagnoses like dilated cardiomyopathy, arrhythmogenic right ventricular, non-specific LVH, myocarditis. Peripartum cardiomyopathy tends to occur in the last month of pregnancy or the postpartum period, but the other presentations can appear at any point. These are going to present essentially as a congestive heart failure or cardiogenic shock. In a case series of maternal cardiac arrest from Canada published a few years ago, this was the single leading cause of maternal cardiac arrest. Okay, so in summary there, in pregnant patients with chest pain and shortness of breath, don't just fixate on PE, remember their increased risk of cardiovascular disease. So next scenario where people seem to make mistakes is when they're faced with a situation where they want to give a treatment and they're not sure if it's safe to do it in pregnancy. Let's go through a case. A 27-year-old female in her first pregnancy who was previously well, presented in the 3rd trimester with palpitations, dyspnea, and orthopnea. Her EKG showed an SVT. She was given adenosine in increasing doses, which was ineffective, and then was given metoprolol. She continued to deteriorate. She developed respiratory distress, hypoxemia, and at this point her heart rate was going at 250. And there were also signs of fetal distress at this point, and so she had an emergent cesarean section very shortly afterwards, had a cardiac arrest. The key failure here was that they didn't do an electrocardioversion of an unstable dysrhythmia. The reports also described an almost identical case to this of a pregnant patient with an unstable SVT who did not get electrically cardioverted. And what seems to be going on is that people are crippled by the fear that the intervention may not be safe in a pregnant patient, and so they didn't do it. When your pregnant patient is really sick, there is a very simple principle to follow. Just treat them that they're non-pregnant. Don't get worried about drug safety. The most important thing to do for the fetus is to keep the mum alive. And there really are no drugs or interventions that are absolutely contraindicated in pregnant patients who are critically ill. Just reminding ourselves of the drugs that are supposed to be avoided in pregnancy. This is from the Rosen's chapter on drug therapy in pregnancy. These are all the FDA category D and X drugs. I've highlighted the ones that we may use in the situation of critically ill patients. So amongst the CNS drugs, that's going to be benzos and phenytoin, which we commonly use in status epilepticus. In seizing pregnant patients, magnesium sulfate is going to be a first-line therapy, but you may need to use these at some point as well. And then in terms of cardiovascular drugs, amiodarone is an FDA category D drug. The reason or the sense in which these drugs are generally contraindicated in pregnancy is for long-term use. But a single 1 or 2 IV doses in an acute situation is almost certainly not going to be harmful to the fetus, and the benefits almost certainly outweigh any risks. No ACLS interventions are contraindicated in pregnancy, and that includes electrical cardioversion. If you are cardioverting a pregnant patient, as much as possible, you don't want the current to pass through the uterus, but if you position your pads properly, that shouldn't happen. And even if it does, the fetal heart has a very high defibrillation threshold. It's very unlikely to be harmed, and there is really no reports from the literature of fetal harm from this. Okay, so next scenario is pregnant patients with a sudden collapse or a sudden syncope or a sudden onset of shock. This is a scenario where there are lots of critical errors made. Let's just go through one example case. A 26-year-old female who's not known to be pregnant collapsed at home. When EMS arrived, she was found to be in cardiac arrest. They did CPR, she got ROSC and was brought to the emergency department. The blood gas on arrival showed a severe acidosis and a hemoglobin of 69. She remained unstable, and a young female with sudden collapse. The presumed diagnosis from the treating physicians was a PE, and she was given thrombolysis. She had some transient stability afterwards, was taken for a CTPA, and the scan was negative. Shortly afterwards, she further deteriorated and died. And the final diagnosis on autopsy was a ruptured ectopic pregnancy. There were countless cases like this of very sick young women, pregnant or not known to be pregnant, coming in. The clinicians would fixate on a specific diagnosis, commonly PE, but sometimes others, and ultimately the patient died as a result. This is very basic advice, but it's a mistake that's easy to make in a critical situation. Avoid premature closure in these patients. This is a differential of maternal collapse or a patient who could be potentially be in reproductive age, based on what were the common pathologies and the common causes of death across these reports. So right up there at the top is going to be some kind of vascular catastrophe. So either a clot, a PE, an MI, or a stroke, a bleed, so a ruptured ectopic, a placenta previa, an intracranial bleed in the context of a hypertensive disorder of pregnancy, and then finally dissections and aneurysms. We already mentioned aortic dissection and spontaneous coronary artery dissection, but I'm also going to talk a bit about splenic artery aneurysm rupture, which is a diagnosis which is frequently missed and which I have to say I wasn't very aware of. Other common causes of shock in pregnant patients, sepsis, toxic causes, and amniotic fluid embolisms. Amniotic fluid embolisms almost always occur during labor or in the immediate postpartum period, so we see it very infrequently. But the others are all things that we might see. So ruptured splenic artery aneurysm. This kind of blew me away. In these reports, looking at the same time period, they had the same number of deaths from a ruptured splenic artery aneurysm as there were from ruptured ectopic pregnancies. I think barely a shift goes by where I don't think of the diagnosis of a ruptured ectopic at some point, but I have to say I have never considered this as a diagnosis. Just like dissections of the aorta and of the coronary arteries, there seem to be physiologic changes in pregnancy which affect the vessel wall, increased circulating volume, hormonal changes which affect connective tissue in the vessel wall, which increase risks of dissections and aneurysms. These patients are going to present with sudden onset epigastric or left upper quadrant pain and shock. They mostly present in the 3rd trimester or the postpartum period, just like aortic dissections and spontaneous coronary artery dissections. And needless to say, this diagnosis is frequently missed. There were a number of cases of this being mistaken either for something like a PE because it seemed like chest pain. There was another case where a patient presented with this, presented in cardiac arrest. She had a perimortem C-section in the ED, she got ROSC, and then was taken to the OR by obstetrics. They spent several hours trying to find the source of bleeding from her uterus. They couldn't find it, and she died. And the problem is that they never extended the C-section incision to look higher up in the abdomen. So this is a diagnosis that even obstetricians don't think of, and something that we should have on the back of our minds in patients with severe abdominal pain and hemorrhagic shock. Okay, so I think a common mistake to a lot of these situations of early closure, early fixation on the wrong diagnosis is people are really focused on the ABCDs. They're really focused on stabilizing the patient. They jump to a diagnosis and don't spend enough time really working through the alternatives. This stuff is basic, but these things were frequently missed in the cases of the patients, in whom the wrong diagnosis was made. So your ABCDs are really good for stabilizing the patient. When you need to think about that diagnosis, think about your EFGs. So E is for exposure. And I really mean really expose your patient. You have to look at the groin. You have to look, is there vaginal bleeding? Are there signs of sepsis emanating from the genital tract? F is for fast, POCUS. I mean, obviously I don't need to explain this to you guys. We're all very good at this. And then finally the blood gas. And I'm not talking about the acid-base status, because the truth is patients who are very sick often have a metabolic acidosis. And what is really useful, and often what was overlooked in these cases, even when the blood gas was done, is to look at that point of care hemoglobin. I think most blood gas machines will give this to you now. Particularly in a case like a ruptured ectopic, by the time the patient becomes hemodynamically unstable from that, she already will have bled significantly, and almost always there will be a detectable anemia. And this, seeing free fluid in the belly or seeing severe anemia can really help shock you out of being fixated on a diagnosis of PE, for example, and so that you don't end up thrombolizing an ectopic, which unfortunately happened in many of these cases because people made the wrong diagnosis. Okay, next scenario is the patient in cardiac arrest. We've already spoken about a few situations of cardiac arrest, but I want to focus a little bit on some of the interventions used in cardiac arrest in pregnant patients and how they may be applied incorrectly or at the wrong time. So the first case is a 27-year-old female who was involved in an MVC in the 3rd trimester. When the paramedics arrived on scene, she was found to be in cardiac arrest, but they managed to get ROSC in the field very quickly, and she was transferred to the ED. In the ED, she remained very unstable. A point of care ultrasound showed fetal death, and an obstetrician declined to perform the C-section because they reasoned that the patient had already got ROSC and that the fetus had died, so there's no urgency in doing the C-section. They suggested that you focus on stabilizing the patient and that they would do the C-section once the patient was more stable. The patient was transferred to the ICU where she died. The key error here was the failure to perform a resuscitative cesarean section. So we know that during arrest, a perimortem C-section is a resuscitative procedure, but even in patients who've got ROSC and the C-section was not performed, if they remain unstable, the C-section is a resuscitative procedure and should be done urgently. Next case is a 23-year-old female who was in labor. She was on the delivery ward and she had a cardiac arrest. Chest compressions were started promptly. She was intubated and moved to the OR for a perimortem C-section. Only once the perimortem C-section was done were the defibrillation pads finally applied. She was found to be in VFib, but despite multiple shocks, they couldn't break the VFib and she died. The key error here was the delay in the rhythm check. She was in an obstetric environment, so perhaps naturally they were really focused on that perimortem C-section, and in the process they overlooked doing the basics of cardiac arrest care. So cardiac arrest in pregnancy is a complex scenario where you need to have multiple roles, multiple teams taking care of different aspects. This is the way I try and remember it, A, B, C, D. So there are 4 different teams or roles, each focused on one of these tasks. A is for ACLS. Don't forget the basics. When I talked about cardiac causes of death, one thing I didn't mention was arrhythmic deaths. That also occurred frequently in pregnant patients, just like in any young people with sudden cardiac death. Arrhythmic death is a relatively common cause amongst the causes. You really need to get the pads on very soon, as you would with any cardiac arrest. B is for baby. There has to be a team ready to receive the neonate, because that neonate, when they come out, is going to be likely in cardiac arrest or very sick. C is for C-section. There needs to be a team focused on performing the perimortem C-section. And finally, and it's easily overlooked when people are focusing on this other stuff, D is for displaced uterus. So let's talk a bit about some of those aspects in more detail. Perimortem C-section. So the way I put it is, it's never too early or too late to do and to think about perimortem C-section. So what I mean by that is that from the moment a patient goes into cardiac arrest in pregnancies, you need to start preparing to perform the C-section so that when you get to that 4-minute mark, you're ready to put knife to skin and to try and get the baby out then within 1 minute. For patients who have a cardiac arrest out of hospital, there were a number of cases described in these reports of prolonged futile resuscitations in the field by EMS, only brought to the hospital after 45, 50 minutes, at which point really the likelihood of benefit from perimortem C-section is much lower. They recommend essentially that any cardiac arrest in a pregnant patient is transferred to an emergency department within, start transfer within 5 minutes. That said, it is really never too late to do a perimortem C-section. It is most effective the earlier it's done, but there are always reports in the literature of sometimes very late survivors, mostly fetal survivors, but even sometimes maternal, far beyond that, that typical 5-minute window. And just to re-emphasize again, as from that first case, even post-ROSC, if the patient did not have a cesarean section during the cardiac arrest, it is still a priority because it is still an important resuscitative intervention. When it comes to relieving aortocaval compression, all the guidelines are consistent now that you should use manual uterine displacement and not lateral tilt. This is very simple to do. It can be done from either side of the bed. Either someone stands on the right and pushes to the left, or they stand on the left and they pull to that side. This is, they've done randomized trials of patients undergoing general anesthesia for C-sections. And before they do the C-section, they randomize them to have the uterus displaced or the patient tilted. And the hemodynamic effects of the displacement are much more favorable. The other problems with the tilting is that it can often impede effective chest compressions, and it's just generally more complicated to do. The nice thing about this, because you have all these complicated tasks people need to be doing during the arrest, anybody can do this. You can get a medical student, you get a PAD, just to push that uterus to one side. Okay, the final scenario where there often were mistakes is in suspected PE. I talked about a few cases where clinicians inappropriately fixated on the diagnosis of PE and neglected other potential diagnoses, but still remember PE is still a very important diagnosis in pregnancy. It's the second common cause of death after cardiovascular disease. I'm going to go through some scenarios and then discuss what the lessons are from them. So the first case is a 36-year-old female in her third pregnancy presenting with leg pain in the second trimester. She was worked up for a DVT. She had a normal Doppler of the lower extremities. Her D-dimer was 20 times the upper limit of normal, but that was dismissed because the clinicians thought D-dimer is not useful in pregnancy. It's always spuriously elevated. She was sent home and she died as a result of her venous thromboembolism. Next case is a 33-year-old female presenting with shortness of breath in the third trimester. She had an elevated D-dimer. Again, that was dismissed as being spuriously elevated because of pregnancy, and she also was sent home and died from a PE. Next case, a 34-year-old female presented with shortness of breath in the third trimester. She was already on prophylactic low molecular weight heparin because of a previous venous thromboembolism, and because of that, clinicians thought that she couldn't have a PE. So she had a chest X-ray, she was sent home, and she died from a PE. Finally, a prima gravida, 33 years old, presented with shortness of breath and collapsed in the first trimester. She had a cardiac arrest in the ambulance. In the emergency department, she had a perimortem C-section. And at that point, even though PE was a suspected diagnosis, no thrombolysis was given due to concern for bleeding after the cesarean section. So these are the mistakes that came up in these cases. First off is the idea that D-dimer is not useful in pregnancy. The second is the idea that you can't have a PE when you're anticoagulated. And finally, the idea that TPA or alteplase is contraindicated in pregnancy or after cesarean section. None of these are true. So first up, D-dimer is part of the pregnancy adapted years algorithm. This is now the best validated algorithm we have to work at PEs in pregnancy. And I think it should be what everyone uses. The study validating this algorithm was published in the New England Journal in 2019. And we're going to go through that on the next slide. The next point, the idea that can patients still have PE when they're already anticoagulated? Yes. Around 1% of pregnant patients who are on prophylactic low molecular weight heparin develop VTE. 1% sounds low, but that's among all patients. Among the subset of patients who present to the ED with symptoms suggestive of VTE, that percentage is going to be much higher, probably in the range of around 10%. So while thromboprophylaxis significantly reduces your risk, it doesn't take it to zero. And in a patient with a compatible clinical picture, they still need to be worked up. And finally, thrombolysis is not contraindicated in pregnancy. But that said, in a patient who, for example, has just had a C-section, you can think about using a lower dose or, if available, catheter-directed lysis. But just as we said earlier, with any intervention in critically ill pregnant patients, think of them like a non-pregnant patient, give them whatever treatment they need. This is the years algorithm, the pregnancy adapted years algorithm for working up VTE in pregnancy. As with any clinical decision rule, the truth is you just need to be aware that it exists, and then you can look it up when you see a patient. But it's a relatively simple protocol in the sense the years criteria are just 3 criteria. Does the patient have signs of a DVT? Do they have hemoptysis? And do you think PE is the most likely diagnosis? If any of these are present, then you're going to do a D-dimer and use a D-dimer cutoff of 500, which is a conventional D-dimer cutoff. But if all these features are absent, then you can use a D-dimer cutoff of 1000. And the advantage of that is then you're much less likely to end up having to image these patients. This has been shown to be safe. It doesn't miss any cases of PE. And I think is really the approach that we should be using in all pregnant patients with suspected PE. Okay, so that's the last slide. Just to re-emphasize, I think, some of the key take-home points. Cardiovascular disease is the biggest killer in pregnancy, but remember that PEs do still matter. In a critically ill patient, when in doubt, just treat them like they're not pregnant. No interventions are contraindicated when the patient is very sick. And finally, in a patient with sudden collapse, syncope, or shock, avoid early closure. Remember the exposure, the POCUS, the point of care, the blood gas, and think particularly about those different kind of vascular pathologies, clots, bleeds, dissections, and aneurysms. And that's the end of my talk. Happy to hear any questions or comments.